the fox who wishes he were a hedgehog. I don't know those of you who've read Isaiah Berlin's book. I was reading that on the way over on the airplane. The individuals in the room here who have had such a deep understanding and deep contribution to this particular condition. So I'll admit my disclosure, I suppose, is that I'm a dilettante in this. I have lots of various interests in cardiac surgery, among them aortic disease. I've got no financial conflicts of interest. I am participating in the PERSEVERE trial, which comes up a little bit in this, although I won't make any recommendations about a treatment with that device. So my assignment, and Eric, I tried my best to adhere to my assignment, was stick to the guidelines, and specifically what the guidelines have to say about aortic dissection. And actually, it gave me an opportunity to review how actually limited the recommendations in the guidelines are. I would argue appropriately. But these are the three sources that I elected to use: the ACC, AHA guidelines that Eric led, and I would add that for those of you who've been involved in guidelines, you appreciate creation of guidelines. You appreciate this. I've never led a guideline document, but I've participated in trying to lead a guideline document. Boy, I tip my hat to you on that one. That is really a matter of herding cats. So the American Heart Association guidelines, the AATS, the American Association for Thoracic Surgery, created its own guidelines. There's a sort of guideline competition, and actually we might have some time in the discussion to talk about challenges with writing guidelines, and this I think is one of them, competition between organizations in writing guidelines, all the reasons for that. And then the recent European STS guidelines, which again highlights the friction that can occur within organizations when they're writing competing guidelines. So I'll start off with a nod to Truls sitting in the back. You'll remember this paper from years ago that he wrote with Craig Miller about asking the question, can the principles of evidence-based medicine be applied to the treatment of aortic dissection? A very fundamental question, and actually the answer is probably not. And I quoted some of the conclusion. You can read it as quickly as I can. But importantly, it talks about the difficulties inherent in conducting stringent clinical studies in surgical fields. Surgical procedures, surgical endeavors in particular are difficult in randomized studies. I would argue for three reasons. One is the numbers problem. If you're going to have a big enough number of cases or a big enough number of events to get to a p-value, that's a challenge in surgery because what we do fundamentally is uncommon. So it's very hard to get numbers enough to get to a p-value that gives you confidence about at least a statistically significant difference. The next problem is selection bias, and there's a huge amount of selection bias in the papers that Santi has talked about. We all appreciate that. That's not a criticism. I guess it is a criticism. It's a criticism of the data. It's not a criticism of the people trying to pull the data together. The man in the arena gets the credit for trying anyway. But selection bias, so for example, if you look at the mortality rate of people with and without surgery, somebody decided that they were or were not going to operate on that patient. And odds are the patient they didn't operate on was a patient they thought was going to die, and sure enough, that's what happened. So one of the other problems is selection bias. On the top end or the bottom end, we either randomize people who we don't think it'll make a difference, they'll do well regardless, or we randomize people that we don't think it'll make a difference, they'll do poorly either way. We do the study, and in the end, the study shows that it doesn't make a difference, and we're surprised by that. And the third fundamental problem with randomized studies in surgical interventions is that everybody does the operation differently. I don't know anybody who does a valve-sparing route, a Tyrone David 5. They all do a modified Tyrone David 5. Whatever it is, and everybody's modification is different. And so that makes it very difficult to do randomized studies, and that makes it very difficult for somebody like Eric to come up with hard data to make really solid recommendations. I also want to acknowledge that when one said, I've seen this in some comments as I've had discussions about these with other individuals, they'll say, well, why don't the guidelines say this and why don't the guidelines say that? Well, you have to appreciate that when you write a guideline, you're writing that guideline for the general public, for the average surgeon. So if you're going to talk about a very aggressive operation, we'll talk a little bit about total arch replacements and so on. It's not just a question of whether Joe Bavaria can do a total arch replacement with the same mortality rate. It's a matter of whether the person down the block can do that operation as well. So it's very complex trying to put together guidelines that are both evidence-based and responsible, I would say, for the care of patients, broadly speaking. But Truls, I think you hit the nail on the head there. So I thought we might talk about some key questions. How best to handle the root? What should be the extent of the distal repair? These are questions we've asked, Joe and we've asked these our whole careers. Nothing's changed in some ways. What should the perfusion strategy be? And how should malperfusion be managed? And that is, I think, the biggest opportunity we have in the technical aspect of aortic dissection. I'm very impressed. I had a sense, Eric, of what the impact of regionalization would be, but you've really demonstrated it very well. I think that regionalization of care and management of malperfusion are the areas that we've got the biggest opportunity to have a big impact. So how best to handle the root? It's a little bit ambivalent. Just for some historical perspective, certainly when I was in training, there was reluctance to be so aggressive as to intervene on the root, to do a root replacement. It was widely held that if you had a patient with a dissection, you just resuspended the root, got out of there best you could, that undertaking a formal composite root replacement was too dangerous a procedure and shouldn't be done. Well, I think that we've seen over time that that's not the case, and the pendulum sort of swings back and forth now, and actually you wind up with a fairly ambivalent response, how aggressive one should be with the root. And I think actually the EACTS, STS comments, this is not a documented guideline a recommendation, but it's in the comments of their text, that the extent of the repair ranging from a supracoronary to composite root really is governed by the extent of the dissection and local expertise, et cetera, so on and so forth. So this, as I said, is not a new topic. When I looked at this, I was appreciative that Eric and his team acknowledged that we wrote about this in 2000 when I was at WashU with Mark Moon. And what we found was, and at this point in time, the question was whether or not it was responsible to be so aggressive. Is it okay to do a composite root replacement? We found that the operative mortality looked pretty similar, that the operative mortality actually looked higher for us with that, with an ascending graft versus a composite graft. Long-term survival and late reoperation not different. And just because I don't have very many pictures in this talk, I thought there might be some non-surgeons in the group. This is what we're really talking about: valve resuspension, resuspending the root, the native valve, and emphasizing complete aortic resection, and then how one deals with the distal and full root replacement. Now, of course, we talk about valve-sparing roots, the Tyrone David operation, valve reimplantation for dissections. There's some enthusiasm for that. And here, Eric, I worry that we're going to popularize valve-sparing roots among non-expert surgeons, and we are going to hurt more people than we help. So I appreciate the reluctance to be too aggressive about recommending a valve-sparing root in the guidelines. I also tried to pull up a few of the particular IRAD contributions to the guidelines, and as Santi said, it's remarkable how many IRAD papers appear in the guidelines. And this, of course, is one addressing specifically root replacement, versus more conservative management. And this is the pendulum swinging back again. So the pendulum swings back and forth between being more and less aggressive with the root. Now, this is most recently from the Stanford group suggesting that reoperation might be greater in limited root repair. Now, note that if the root is involved, if it's a patient with Marfan syndrome, if it's a patient with a bicuspid valve and a dilated root, certainly most of us in this room would tend to be more aggressive with that. Although I do still tell my residents that the prerequisite to a good long-term outcome is a good short-term outcome, and so the most important thing is to get the patient out of the operating room alive with whatever you're most comfortable with. Well, what about the distal extent? There's a lot of excitement around distal extent, especially around frozen elephant trunks. Hemi-arch recommended over more extensive arch replacements in the ACC AHA guidelines. And I think that again is a very responsible comment. What some of you in the room might not be aware of is that the vast majority of dissections, over 50% of aortic dissections in the United States at least, are performed in low volume centers, very low volume centers. And so most dissections are done by non-expert aortic surgeons. So a recommendation to the general population that a hemi-arch replacement rather than a total arch replacement, I think, is a very responsible recommendation. Now, a 2B recommendation for a more extensive repair if there's a tear in the arch, and you can see the AATS guidelines suggest that an extended arch replacement is reasonable with a primary tear in the arch, or if there's brain or peripheral malperfusion. Again, there's a lot of interest in how to best treat malperfusion. And extended arch replacement may be considered in young patients and Marfans, et cetera. I had to have a nod here to Joe and his impact on our thinking about frozen elephant trunk. And again, a very responsible, I think, publication that demonstrates that while it makes all the sense in the world that a frozen elephant trunk would improve your long-term outcomes and reduce late reoperation. These are the data. Stented and standard repair. You've got to get a few years out there to see the impact on distal remodeling. A sidebar about IRAD data, hemi-arch versus total arch replacement. This is a recently conducted study that Arminder Jasser did, comparing data up to June 2023, only DeBakey ones, looking at patients with malperfusion and only patients who underwent surgery first. There were three groups: hemi-arch, arch, and arch with descending thoracic grafts. And the mortality rate and the neurologic outcomes and such were actually worse with the total arch, but of course, these are patients that are having arches for a reason. They're having an arch likely because they've got these kinds of complications. In non-malperfused patients, importantly at the bottom there, the conclusion, in non-malperfused patients, arch and total arch and arch with a frozen stent graft were worse than a hemi-arch. So again, it makes sense to recommend, broadly speaking, a hemi-arch replacement, and those are IRAD data. In malperfusion patients, the arch was worse than the hemi, but no increase with the distal stent, and this is likely because the procedural risk is mitigated by the benefit derived from treating the descending aorta. So the malperfusion is benefited by the stent graft, even though it's a more complex, more extensive operation. Perfusion strategies, we go around and around about that. Some approaches around whether we cannulate the axillary artery. Direct cannulation is gaining a lot of interest. It was the traditional way to do it in the old days, and it's gotten a resurgence of interest. I don't know if John Eleftheriades is in the room right now, but the femoral cannulation is getting dissed here. John, I think, has demonstrated that actually that's a very reasonable way to manage a dissection. So When you actually look at the data and parse the data, this, I think, is an example of one of those things where we sort of have a sense, there's a momentum within the aortic surgical community to go to these other approaches. But if you actually look at the data, it's pretty hard to prove that there's anything wrong with femoral cannulation. I think that's a fair statement to say. There's a comment about adding ACP and RCP, some kind of cerebral perfusion strategy. When you look at the studies, you'll see a better outcome in general. The retrospective, multi-institutional, multi-center studies, if you compare the outcomes of patients who had cerebral perfusion strategies versus those who didn't, those who had cerebral perfusion strategies oftentimes do better. My bet would be that those are the individuals that are getting treated in the places that Eric just talked about, the places that are high volume centers with aortic expertise, and those are so there's an element of selection bias in that. It's really hard to prove. Another little IRAD sidebar, a recent study that Stanley Wolf did with IRAD. Mild perfusion is a bad problem, and just to reemphasize that, for mesenteric malperfusion, while it's not the most common kind of malperfusion, it is by far the most lethal kind of malperfusion. It's the kind, I think, it's the type that we perhaps dread the most. Mesenteric malperfusion has almost a 5-fold increased mortality rate. Compare that with coma, which is a bit less than 2. And of course, the long-term outcomes in that study. So how should malperfusion be managed? In general, most surgeons, most recommendations are to go ahead and do proximal correction first. I do think that makes good sense, again, with the thought that you're talking about the general population. That may not be true in Atlanta or in Ann Arbor, but in most other places, patients get their ascending aorta treated first. Note, surgery can be effective in thoracic aorta, in type A dissection with brain malperfusion. Santi already quoted this study from IRAD that demonstrates that people do better with surgery, and up to 80% of patients with coma or CVA do better with surgery than not. So I'll wind up the ACC-AHA approach to malperfusion. They've got a nice algorithm there, particularly with mesenteric or renal malperfusion. It lets you go either way, endovascular fenestration or immediate ascending arch replacement there in the middle. It's unclear what to do with that, and I think that's a fertile area for investigation. Just a brief comment about this trial. Again, I'm not hawking this device. I'm not on the scientific advisory board or anything, but it's to remind me to suggest that I do think the place that we've got the greatest likelihood of getting any kind of good prospective randomized data are actually from industry-sponsored trials. They're expensive, they're hard to run, but you get people who are committed to them and are willing to enter patients into those studies, and I think that that's a way for us to get the kind of information. This is what the device looks like. It's an intriguing idea of doing not even a hemiarch replacement, just an open distal anastomosis with this sort of slinky in the descending aorta to try and correct malperfusion. The AATS summary about the treatment of acute aortic dissection, basically recommending axillary and direct. We talked about that. Valve resuspension in most patients. We talked about that. The entire ascending aorta with visible primary entry tear and a open distal anastomosis. There's no better data now about open distal anastomosis than there was when Truls did it. It just happens that's the way most of us do it. It's a nice way to do it. There are a lot of appealing aspects, but if you ask about prospective randomized data to prove it, they're thin, and certain conditions might require arch replacement and malperfusion, as you can see. This is the EACS summary, and I'm running out of time, so I'm just going to quit there with this final slide. This is what I think the